Hello, I'm Mark and welcome back to this series on evidence-based medicine. In the last video, we explored the basics of evidence-based medicine. Today, we are going to discuss therapies. In our careers, we have thousands and thousands of consultations, and in each one of those consultations, treatment decisions will be discussed. That could be doing nothing, it could be considering the pros and cons of a drug, or a non-drug option such as physiotherapy, a psychological intervention, or a complex intervention. But how do we know that that treatment decision is beneficial for the patient? How do we weigh up the pros and cons? And how do we support our patients to make the best decision for themselves? Well, that's where the critical appraisal of our treatment evidence comes in. So let's get into it. As a quick recap, as we mentioned in the last video, clinical epidemiology is the science of linking an exposure to an outcome. And if the researchers assign that exposure, that is called an intervention. And randomized control trials are the gold standard of how interventions are assessed. So interventions, treatments, therapies, they are all interchangeable terms. Examples of therapies could be a drug. That could be something like a statin, an antihypertensive, or an SSRI. Maybe it could be a non-drug treatment such as CBT, a physiotherapy or surgery option. It could be a complex intervention, which would be an intervention with multiple subcomponents that might try to change the behavior of a patient. They could be lifestyle or system level changes such as smoking cessation, exercise programs, structured diabetes care. All of our therapies should be tested through randomized control trials, which, as we learned in the last video, are a mechanism to remove the concept of confounding, which is inherent in observational research. Our therapies can also be tested when we pool multiple randomized control trials together into a systematic review of randomized control trials. And today we're going to mention both randomized control trials and systematic reviews of randomized control trials. Here's a scenario. What if I was to offer you one of these three drugs? Which would you take? The first drug would reduce your risk of having a heart attack by 50%. The second drug would reduce your risk of having a heart attack by a total of 1%. There's a third drug. 100 people would have to take that drug every day for 5 years, and only one of those people would benefit. 99 people would take the drug without accruing any benefit at all. What drug would you choose? Unsurprisingly, most people choose option 1. But what if I told you that each of these three drugs is the same? It's pretty confusing, right? Well, this underscores just how important it is to critically appraise the evidence we have. To help us understand the phenomenon above, let's create a fictional randomized control trial. So we have 1,000 people who are randomized to two groups, an intervention group and a control group. The two groups are followed up, let's say for 5 years. And perhaps there's a little loss to follow up, as we can see here. Evidence is about linking an exposure to an outcome. So the outcome here is, well, we said it's mortality. And in the intervention group, we can see that 5 people died. And in the control group, we can see that 10 people died. So that is called the experimental event rate and the control event rate, respectively. So critical appraisal, as we've mentioned before, involves 3 aspects. Firstly, what is the result? What is the effect size? Is it statistically significant? Does it matter? And secondly, the validity. Is this study biased? And largely we're looking at the methods of the study there. And the third step is applying that to the patient, applicability. So just on the first component of appraisal, what is the actual result here? Well, we're going to assume that the difference between the intervention and control group is statistically significant. So now we can go on to believe that the result is not due to chance. So how effective was the drug? And there are a few ways of articulating that. So a relative risk reduction is done by comparing the result of the intervention group compared to the control group. This formula looks a little complicated, but in essence it says relative to the control group of 2%, how effective was the drug? So 2 minus 1 over 2. So the relative risk is 50%, and that sounds very impressive. The absolute risk reduction is different. it takes a bigger picture. How effective is the drug overall? Well, that would be simply 2% minus 1%. So the drug reduces the risk of death by 1% over 5 years. It is the same drug, just a different way of articulating really the same thing, but it certainly appears more modest. As we can see here with numbers needed to treat, this is really an inversion of the absolute risk. It divides the number 1 by the decimalization of the absolute risk reduction, in this case 0.01. So this gives the number 100. So that means that 100 people would have to be treated with the drug, but only one person benefits. And that means that 99 people don't get any benefit and they could actually get side effects. So going back to the scenario I showed you above, the effectiveness of a therapy can be articulated in several different ways. Some, such as relative risk, can make the therapy appear more effective than maybe it actually is. And I think there's a big difference between relative and absolute risks, and it's probably more appropriate to use absolute risks when we share decisions with patients. The second part of critical appraisal looks at validity. Is the study biased? I'm looking at the methods. Was this a well-conducted study that I can believe? In this fictional randomized trial, we might look at the following. Firstly, we could look at table 1 in the results, and that looks at the baseline characteristics in the intervention and the control group. And if there was an issue or a bias in how randomization was done, the characteristics in the two groups might be different. The ages might be different, or the gender might be different. And that could infer that confounding could have crept into the randomized trial, and that's a bias. That would be called selection bias. A second type of bias to look for would be performance bias. That's when something else happens to the intervention group. Maybe they had an additional support from a nurse or something like that, and that could be the ingredient that underpinned the effectiveness of the drug rather than the drug itself. So you're looking at something called performance bias. If there's a significant amount of loss to follow-up in the intervention group, there could be some sort of harm from the intervention. That would be called attrition bias. If the variety of outcomes weren't blinded, that could be something called detection bias. And there can be multiple other sources of bias in randomized trials, such as reporting bias, selective outcome reporting, and also funding issues, which could raise issues with conflicts of interest. So now we've appraised whether or not the study is valid. The third step in appraisal is applicability, and we want to assess whether or not you can apply this result to your patient. So where the trial patients, like your patient sitting in front of you. If you're a GP, was the treatment delivered in a primary care setting in the trial? If your patient has 10 medical conditions, is on 15 medications, but the patients in the trial had only a single disease, maybe this trial is not generalizable to you and your patient. So you have to weigh this up, and that brings in the issue of uncertainty, which we all live with, particularly in general practice. You also have to think about the outcome. If the outcome is a score that doesn't particularly matter to the patient, or if the outcome is mortality or quality of life, it's quite obvious which is the more important outcome for that patient, and that's up to you to interrogate. So to help consolidate this learning, let's look at a real world study, and we might look at the evidence base for Paxlovid, which is an antiviral for COVID-19. This was a study that was published in the New England Journal of Medicine in February 2022. It's always worth writing out a flow diagram, that's called a consort diagram, and writing out our PICO constructs. So in terms of the PICO, the population were patients who had COVID-19 for less than 5 days. And this was early in the pandemic, they were high risk and they were unvaccinated. So they were elderly and they had medical conditions. The intervention was receiving Paxlovid for 5 days. The control was placebo. And the primary outcome in this case was a composite outcome. So it was death or hospitalization at 28 days. So looking at the study here, we have over 2,000 patients that were randomized to two groups, one getting Paxlovid, 1,120 patients in this arm, and the other arm getting a placebo tablet, that was 1,126 patients. They were followed up at 28 days, and the primary outcome was measured hospitalization or death. So you can see that 5 patients were hospitalized or died in the intervention group and 44 in the control group. So again, there are 3 layers to appraisal: the result, the validity, and applicability to your patient. So in terms of the validity, let's just assume that this is a really well conducted randomized trial, and I think it was. It was published in the New England Journal of Medicine, and I don't think it has a significant number of biases. So we might believe the results. So moving on to this, a second component is the result itself. So in terms of the results, I would say that the difference between the intervention and the control group in terms of the primary outcome was statistically significant. So now you can move on and actually look at the clinical significance itself. The abstract in the New England Journal certainly said that this drug was really effective. So let's interrogate this and look at the absolute risk. So the relative risk reduction is how effective the Paxlovid group is compared to the placebo group. And this is reflected in an equation which would be 3.9% minus 0.4% over 3.9%. And that gives a number of approximately 90% relative risk reduction. That is unadjusted. This is without doing any statistical tests. In terms of the absolute risk reduction, well, that looks at the control event rate, 3.9%, minus the experimental event rate, which is 0.4%. And that would give an absolute risk reduction in the primary outcome of 3.5%, which sounds very different to 90%. The number needed to treat is the inversion of the absolute risk reduction. So that's 1 over 3.5% or 0.035, and that is equal to 29. So that would mean that 29 people would have to take Paxlovid in this population for 5 days, and 1 person would benefit and 28 people would not get any benefit. So let's get into applicability to your patient. Well, what happens if it's 2025 and your patient has been vaccinated 6 or 7 times and may have developed COVID a few times already? Maybe their background medical conditions are a little bit different to the medical conditions in this study. Perhaps you would like another randomized trial to have been conducted in the last year in which vaccinated and patients who had COVID-19 were tested with Paxlovid to see if it's effective. But that trial doesn't exist. So you are dealing as a doctor with uncertainty. There is an absence of evidence, and you're using the best available evidence with patient preferences and your clinical experience to guide you in the best decision for the patient. So let's leave randomized controlled trials and let's move on to systematic reviews of randomized controlled trials. Systematic reviews bring all the evidence available for a therapy together by pooling multiple trials together. And we might remember that in the hierarchy of evidence, a well-conducted systematic review would sit above a randomized control trial. So it is unsurprising that most of the drugs and therapies that we use in everyday clinical practice will have a systematic review of randomized control trials underpinning them. And we need to understand how to critically appraise a systematic review. When appraising a systematic review, we broadly look again at 3 components. First of all, the result. What is the result of the systematic review? There will be primary outcomes, secondary outcomes, and usually in a systematic review, the primary outcome might be graphically represented in something called a meta-analysis or a forest plot. In terms of validity, one way in which a systematic review can be assessed, one component is graphically through a risk of bias chart, and roughly you can see the amount of bias inherent in all the sub-studies within the systematic review. So in terms of results, let's look at a systematic review, and we'll look at the forest plot from a review from 2018 by Illich et al. On prostate cancer screening. So here is the forest plot. Here we can see there are 4 rows, and each row reflects one large randomized control trial. This line here represents something called the line of no effect. Each randomized trial is summarized with a square being the result of the trial, and the confidence intervals reflecting the lines around the square. So if the line crosses the line of no effect, this study is not statistically significant. And systematic reviews are really useful here because rather than one expert or doctor saying that they believe this randomized trial and another doctor saying they believe that randomized trial, systematic reviews pool all the trials together. And the summary of the meta-analysis, this diamond, it's called the pooled point estimate. This is the result of the systematic review. And if this crosses the line of no effect, well, the outcome is not statistically significant. And then you wouldn't even go on to consider whether or not it is clinically significant. It's not statistically significant. So in this case, from one systematic review from 2018, which is now 7 years old, prostate cancer screening did not improve all-cause mortality. All therapies have benefits and harms. The benefits can be represented through the number needed to treat, which are derived from randomized trials and systematic reviews of randomized trials. And harms can be also summarized as the number needed to harm. It's patients who decide on what treatment option is best for them. Doing nothing, option 1, option 2, option 3, and the pros and cons of each of those options. They'll decide which treatment direction is best for them in conjunction with you by weighing up these pros and cons. So we have to understand what those pros and cons are. One resource to look at the numbers needed to harm and numbers needed to treat is a website called the NNT. So let's look at some common NNTs and NNHs just to tease that out. So for acute otitis media in children, there's no benefit for prescribing antibiotics in terms of reducing pain. But 1 in 33 children would benefit in terms of tympanic membrane perforation. In terms of harm, 1 in 14 would experience vomiting, diarrhea, or rash. So that's the kind of trade-off. In terms of mild hypertension in adults, a risk factor for future cardiovascular disease, well, for mild hypertension, there's probably no benefit in an antihypertensive, but potentially up to 1 in 12 people might develop a side effect or have dizziness. And in terms of statins for adults who have cardiovascular disease, there's a very strong evidence base there. And we can see that depending on the overall cardiovascular risk, 1 in 83 would get a mortality benefit and 1 in 39 would have a MI prevented. So that's very good. Potentially 1 in 50 might develop diabetes for some reason because they're on a statin, and up to 1 in 10 have a muscle pain. So there are pros and cons, and I guess you might have an idea. Obviously, mortality is very serious, but patients might have their own idea about the relative benefit of those pros and cons. And it's just us to share those decisions with patients and let them decide for themselves. And that's medicine working really well. I'm going to mention some pitfalls when we're interrogating evidence for therapies. Surrogate outcomes, for example, lowering cholesterol, that doesn't necessarily translate into a meaningful outcome like reduced mortality. So we have to be careful of surrogate outcomes when we're talking about therapies and interventional research. We have to be very mindful of industry funding. So you'd be looking at funding sources on our research papers in case that introduced bias. Publication bias is a real issue. So negative trials sometimes never see the light of day. I'd say quality improvement is crucial in local sites, and it's our professional responsibility to engage in QI each year. But improving quality in one site does not mean that this would work necessarily in another setting. And technically, it is not research. I'd also have say a word about generalizability. So there might be a randomized control trial from a hospital-based setting, but that might not reflect the real-world setting in general practice where patients might have multimorbidity. So today we learned how to critically appraise a randomized control trial and a systematic review of randomized control trials. We learned that absolute risk reduction is a more appropriate and probably more accurate marker of how effective a drug is, and that number should be used in the tools we use to share decisions with patients. We've learned that most people do not benefit from the drugs which we prescribe. Even our most effective medications in medicine, most patients do not derive a benefit, and some may get harmed. And that should instill in all doctors humility when we treat patients, and also might help us de-prescribe medications in the future. Many conditions in medicine resolve spontaneously. They resolve on their own. So understanding the natural condition of many conditions that can self-resolve over days or weeks is very important, and we need to be able to share that with our patients. And I say that because sometimes conservative approaches, watching and waiting, doing nothing, can be a very effective intervention, and that is really important for us and a really important tool for us as doctors, as long as we can safety net and follow up the patient appropriately. Caring, kindness, being compassionate, truly listening to patients, they are arguably far more important as interventions than our drugs and therapies. So it is incumbent on us as ethical and professional doctors to live those values as doctors, and to really care and really listen and to be kind in the consultation room. And lastly, how can you share some of these really complicated concepts with patients? It's important for us as a wider discipline, particularly our professional training bodies that create guidelines, to create aids that can accurately empower patients and also support us in the variety of treatment options that are available to patients. We have to remember that the best therapy balances three components: your clinical experience, the patient preferences, and the best available evidence. So that's a whistle-stop tour of therapies in medicine. In the next episode, we're going to talk about the evidence underpinning observational studies, cohort studies, case control studies. We're going to talk about risk factors and how we can support patients in understanding their future risks. Thanks so much for watching. See you next time.